All right. I would like to welcome you again, and thank you to giving me this opportunity to present this quick and heavy review at the same time, esophageal diseases. So I'm going to start with a quick revision of the anatomy of esophagus. So we all know we all know that the esophagus is a muscular tube that about 25 centimeters, start from C6 to T11. Naturally, we have three narrowings. The three narrowings, the first one is at the level of the upper esophageal sphincter, which is 15 centimeters. And the second one is it's in the thorax, where it is crossed by the aorta and the left main bronchus. The third narrowing is at the level of the lower esophageal sphincters. Those narrowings have a clinical importance because most of the food impaction and perforation almost occur there. So as I said, there are three parts, the cervical part and thoracic part, abdominal portion or abdominal part. The blood supply in the neck is driven from the inferior thyroid artery, whereas in the chest, it comes from either the bronchial arteries or directly from the aorta. And in the abdomen, it is an ascending branch from the left gastric artery. The venous drainage more or less corresponding the arteries. In the neck, it's the inferior thyroid vein. In the chest, it's actually drains into azygos and the hemiazygos. And the abdomen drains to the portal vein through the left gastric vein. An important point you have to understand that the venous drainage of the esophagus is actually longitudinal drainage in the submucosa, and it's very important for us as a surgeon in case of esophageal cancer that we have to be as far away as possible from the tumor. So that's why it's very important to know this piece of information. And the abdomen, the venous drainage is drained into the left gastric lymph node and eventually into the celiac lymph node. If you want to operate on the esophagus and foregut in general, you have to understand that the esophagus is surrounded by very important structures, scary structures actually. The first one is the aorta, which lies just below the esophagus at the level of T12. Whereas the inferior vena cava is situated just to the right of the esophagus at the level of T8. The mucosal wall is basically has three or four layers. Mucosa, the esophageal wall. It has mucosa, submucosa, muscularis, and adventitia. The mucosa is lined with non-keratinizing stratified squamous epithelium. The submucosa is rich with lymphatics, blood vessels, and the glands. Whereas the muscular layer, we have two types of muscles in the esophagus, the inner circular and the outer longitudinal. The upper part of the upper third of the esophagus is completely made of striated muscle, whereas the distal third is made of smooth, completely smooth muscle. An important piece of information that we have two sphincters in the esophagus, the upper esophageal sphincter, which is a true sphincter. It is voluntary, made of mainly cricopharyngeal muscle, whereas the lower esophageal sphincter is a physiological sphincter. This is not a true sphincter, and is made up from both anatomical and physiological barriers. For example, when the esophagus joins the stomach, it joins it at acute angle. The wall compression by both factors, the righted thrust, which called Pinchcock effect, and the positive intra-abdominal pressure. Last but not least is inside the esophagus, actually the mucosa is folding. So we call those folds rosate folds or mucosa folds. We have three parts, we have three types of peristalsis in the esophagus, primary, secondary, and tertiary. Primary and secondary are physiological peristalsis, but tertiary is actually pathological and non-coordinated peristalsis, usually we find it in achalasia, for example. Luckily, the esophagus has a natural defenses to reflux disorders or reflux disease. We can divide those natural defenses into anatomical mechanisms and physiological barrier. So anatomical mechanisms, the most important ones are the Pinchcock effect of the crural from the diaphragm, the oblique angle of the entry of esophagus into the stomach, and a mucosal rosette that we discussed earlier, plus the phrenoesophageal membranes. Those natural defenses mechanisms can be easily breached and disrupted when you operate at the foregut, in the foregut. Whereas the physiological barrier, we have the clearance mechanism of the reflux, of refluxate, which is the peristalsis and the saliva. The saliva has a role in pushing the acid back to the stomach, and also it neutralizes acid inside the esophagus. Right, so move on to the actual disorders of the diverticulum, of the esophagus. The first one is esophageal diverticulum. Although it's rare, but it may occur in any part of the esophagus. We have two types of diverticulum, a true diverticulum and false diverticulum. The true or traction diverticulum usually asymptomatic and there is no underlying motility disorder. The causes are basically inflammatory reaction around the esophagus, whereas the false and pulgent diverticulum made of mucosa and submucosa, there is most of the time there's motility disorder underlying, and the most popular ones are Zenker's diverticulum and epiphrenic diverticulum. So let's move on to Zenker's diverticulum, which is a pulgent diverticular. It usually protrudes through the Killian's triangle. The Killian's triangle is actually the bare area of the esophagus, and it is at the back of the esophagus. It is bordered superiorly by the inferior constrictor muscle and inferiorly by the tracheoesophageal muscle. The pathophysiology behind it is an increase in intrabolus pressure during swallowing, with an inadequate opening of the cricopharyngeal muscle during swallowing and during the bolus. So with time, this area actually becomes bigger and weaker. Eventually, you're going to end up having diverticulum. Those patients present with many symptoms: dysphagia, choking, regurgitation, halitosis. Sometimes, if you are lucky enough or big enough, you're going to feel or you're going to hear the diverticulum on the side of the neck. If it is severe and big enough, the patient may present with weight loss or sometimes with respiratory symptoms because of the aspiration of undigested food. Unfortunately, although to very small chance that the diverticulum may harbor cancer cells in less than 1%. Zenker's diverticulum may be associated with GERD and hiatal hernia in about 44 to 45% of the time. And that's basically why we have to make sure that we examine the whole esophagus. If you want to evaluate now Zenker's diverticulum, we always start with history and physical examination. And I think that the gold standard for diagnosis of Zenker's diverticulum is barium swallow. Barium swallow can give us like a lot of information about the presence of the diverticulum, location, the size of the diverticulum, and also it gives us basically information about whether there's an underlying strictures or tumors. But whenever you want to investigate the Zenker's diverticulum, you have to do an upper GI endoscopy. Either you do it yourself, or at least establish some sort of communication between you and the gastroenterologist. The reason is you want them to do a careful and a slow endoscopy with probably a small scope, so that you would like to avoid a perforation of the zincers by mistake. Manometry, I think, is important. I want to rule out any underlying motility disorder. And then those pieces of information here, it allows me to plan my surgery in a proper way. A treatment of zincus diverticulum is basically, we have both techniques. We have two techniques, either an open conventional technique or we have an endoscopic technique. The conventional technique is probably the gold standard now. And the most important step you would like to do or to know is myotomy. So you can do resection of the pouch and then you do myotomy, or you can do diverticulopexy and myotomy. Pexy is when you invert the pouch upside down, so that you will the food basically will not enter the pouch, and the attachment is usually at the or on the prevertebral fascia. So again, myotomy is very important, or the important step. If you didn't do it, then the chance of recurrence will be very high. So the approach of zincus treatment or zincus surgery, usually we start on the incision is going to be on the left side of the neck, anterior to sternocleidomastoid. And when you go down, you have to divide the omohyoid and the middle thyroid vein. Once you are inside, then head down directly to the prevertebral fascia, encircle the esophagus completely. If you finish encircling, basically you can identify the pouch, dissect down the pouch until you reach the neck. Before you dissect or before you resect the pouch, you have to complete your myotomy. So what you need is basically 3 to 4 centimeters distally, like here, or 2 to 3 centimeters approximately. With this, you will conclude your surgery. You don't need to put a drains, of course, and what you're worried about post-operatively is usually fistula and leak. So post-op day one, I usually order a barium swallow to confirm that the patient is basically there is no leak from our staple line. The other technique is endoscopic technique. Endoscopic technique is a very nice one. Basically, I've done it probably once or twice. It requires a general anesthesia. And the idea behind it is that you join the pouch with the lumen of the esophagus. So there is a common wall here. This common wall is stapled and divided. The thing that the pouch usually stays in place. So the recurrence is always a problem in this kind of technique. And the other problem is that if it is a small pouch, the myotomy will be very short, so that will lead us to more recurrence than the conventional resection and myotomy. Post-operative complication is probably low, but you always worried about the recurrent nerve injury and leak or perforation, but the mortality is very small percentage. Mortality is probably less than 0.5%. The other diverticulum is the one occurs in the esophageal body. Again, it's a Pulsion diverticulum, usually occur on the right side because the left side is occupied by the heart. Those patients present with dysphagia, sometimes chest pain. If the pouch is big, then they might present with regurgitation and aspiration, or complication of the pouch, which could be erosion, bleeding, fistula, for example. Again, it may harbor cancer cell, probably less than 1%. The thing about diverticulum of the body, or epiphrenic diverticulum, 2/3 of the time, it is associated, or there is an underlying esophageal motility disorder. Investigation-wise, more or less the same as Zinker's diverticulum, but here I emphasize on the high-resolution manometry, because you would like to rule out an underlying motility disorder so that you can map and plan your surgery accordingly. So the treatment of epiphrenic diverticulum, if it is small and asymptomatic, don't bother, no need for treatment, just watch those patients. But if they are symptomatic, then you have to treat the diverticulum and treat the underlying motility disorder. The treatment of this kind of disease or disorders is usually resecting the pouch, and opposite to your resection, always do a myotomy. 100-degree opposite to your diverticulectomy, you do your myotomy, and then always conclude your procedure with a partial anti-reflux surgery or partial fundoplication. Of course, we can approach the epiphrenic diverticulum by through the thorax by VAT, or through the abdomen, either open or laparoscopically. We'll shift gear now to hiatal hernia. I think it's pretty common, and we see it almost on every basis, which is defined as herniation of abdominal content into the chest via hiatus. It's classified into two, either sliding or paraesophageal hernia. And we have four types. Type 1 is a sliding hernia, in which there is the GE junction is actually above the diaphragm, and the stomach or the fundus is below GE junction. Okay, this is type 1, where it's a sliding. Type 2, 3, and 4 are a true paraesophageal hernia. Those paraesophageal hernias, they have actually hernia sac, in which there is an upward dislocation of the fundus. So in type 2, for example, the fundus is the leading point here, whereas the GE junction is below the diaphragm. So the herniation is in the fundus. This is type 2. Type 3 is a combination between both type 1 and type 2. So the GE junction and fundus are herniated, and the fundus is still below the GE junction. Type 4 is a large hernia, or sometimes I call it a complex hernia, in which there is other organ involved, like colon and spleen. The most common type is actually type 1, and most of the time the patients are elderly patients, or overweight, or they have had multiple pregnancies previously, or had a previous esophageal surgery. Type 1 sliding hernia, the pathophysiology behind it is actually there is a laxity of the phrenoesophageal membrane. It's not defected, it's just lax. So when the GE junction is above the diaphragm, that means that most of the defensive mechanism, natural defensive mechanism to GERD is gone. For example, you know, the pressure is changed in the chest, or the pinchcock effect of the diaphragm. It used to be for the lower esophageal sphincter, but now it's actually it's pinching against the fundus. So reflux or GERD disease is very prominent in type 1, and there is absolutely no hernia sac. Type 2, 3, and 4, almost all membranes surrounding the esophagus and the stomach are lax. And most of the time, those hernias are large hernias, not giant, but large hernias, and may be complicated by volvulus. We have two types of volvulus that you have to understand. We have the organoaxial volvulus, in which the stomach is twisting around the longitudinal axis, whereas the mesenteroaxial volvulus is folding or flipping of the stomach around the transverse axis. Patients with paraesophageal or sliding hernia most of the time are asymptomatic, but type 1, if they are symptomatic, they present with GERD symptoms like heartburn, regurgitation, and dysphagia. Whereas type 2, 3, and 4, if they are asymptomatic, the symptoms are a little bit more prominent than type 1, of course, epigastric pain, fullness, or they may present with a complication like volvulus bleeding from Cameron ulcer. So Cameron ulcer is an ulcer that occurred due to the compression of the diaphragm on the stomach. So the ulcer of the fold in the stomach is not in the esophagus. And of course, if it is big enough or severe enough, those patients, they may present with respiratory complication like aspiration, pneumonia, or increasing attacks of asthma. So a careful history and examination is warranted in those populations. The barium swallow probably is the most sensitive test. Barium swallow in paraesophageal hernia is very important. It gives you a lot of information like the size of the size of the hernia, the size of the hiatus, and to some extent you may assess actually whether the esophagus is short or not, and we'll explain that down the road. And again, to some extent, you may assess the motility of the esophagus with hiatal hernia. Endoscopy is crucial in this situation. Endoscopy will give us the opportunity to assess the mucosa of the stomach and the esophagus, and to make sure there is no underlying problem like strictures or ulcerations or tumor, for example. And also, beside the endoscopy, I usually ask for manometry just to make sure there is no underlying motility disorder. CT scan in this situation, I think it's very important. The reason, because I would like to know what's going on in the chest, and I would like to know the size of the stomach inside the chest, the relationship of the hiatal hernia to the surrounding structure, and whether there's any complication like volvulus or not. So for treatment of hiatal hernia, if you have a sliding asymptomatic, then you can observe, you can conserve basically. You don't have to worry about surgery. But if they are symptomatic, then you should start treating GERD. Most of the time, you're treating the GERD medically or sometimes surgically. But if you have paraesophageal hernia, if they are asymptomatic, then it's debatable. There are two schools. One of the schools says, you know what, you don't have to worry about it, because if you operate, the mortality will be the same as if you didn't operate. The other school says, like, basically that you have to operate. You want to avoid a future complication. To be honest, like, you know, my background is whenever I see a paraesophageal hernia and the patient is healthy, otherwise is good candidate for surgery, I usually offer surgery for them. Definitely, both sliding and paraesophageal hernia, if they are symptomatic, then they need to repair. And if they present with a complication like volvulus or bleeding or strangulation, then those patients should undergo an emergent or urgent surgery. The medical treatment for hiatal hernia, I always ask my patient or tell my patients, you have to change your lifestyle. At the same time, I would start them on TPI for 8 to 12 weeks. And those drug treatments actually eases up the symptoms until we do the most or more definitive treatment like surgery. Indication of surgeries in paraesophageal hernia: one, if you have symptomatic paraesophageal hernia, or if you have a sliding hernia with GERD and volume regurgitation despite the PPI or on PPI. Young patients, healthy, asymptomatic, I usually offer surgery for them. And I never deny surgery for octogenarian patients, those patients above 80 years of age. You know, if they are healthy enough, I think I should not deny surgery for those patients. So the repair of hiatal hernia could be done either transthoracic through the left thorax or transabdominal. And transabdominal probably now more common, especially the minimal invasive surgery, in which we reduce the content of the hiatus, and then we do a fundoplication. We'll talk about the surgery later on. We have two types of fundoplication, either Nissen, which is the standard one, especially if there is no underlying motility disorder, or Toupet, which is a partial fundoplication posterior 270 degrees. Again, we'll talk about it shortly. A variant of hiatal hernia is called giant hiatal hernia, which is defined as more than 30 to 50% of stomach inside the chest. It's fairly common actually among those patients, usually in elderly patients. The reason behind that is because those patients, the elderly patients, they have decreased muscle bulk, decrease the tone of the muscles, and loss of elasticity. Eventually, those mechanisms lead to thinning and widening of the hiatus. That's why, you know, the stomach, most of the stomach actually can easily ascend upward inside the chest. The clinical evaluation of those patients more or less the same as the hernia, but they may present with complications like volvulus and iron deficiency anemia. Chest X-ray sometimes is more than enough to diagnose hiatal hernia. Actually, you will see a large bubble just behind the heart that is filled with air and fluid. But the gold standard to diagnose those patients is barium swallow. If I have the facility, or I should basically ask for manometry. Again, in this situation, the manometry will help me to assess the peristalsis and to check whether there is an underlying motility disorder. It's very important to do it preoperatively because I want to map my surgery correctly, and I want to plan the type of repair for those patients. Also, it's very important to address whether those patients have short esophagus or they don't have short esophagus. Endoscopy is critical here. Usually I do it myself, but if you don't do it yourself, then you can communicate well with your gastroenterologist to tell you what are the findings, especially to address the location of de-ejection to the diaphragm. Also, you know, you have to make sure that there is no underlying GERD complication like esophagitis and Barrett's esophagus. So the treatment is for giant hiatal hernia is surgery. Any patients with giant hiatal hernia, you have to offer surgery for them, because if you didn't treat them or operate on them, then they may have a fatal complications up to 30%. What about those patients? They come to you with obstructive symptoms. So those patients, you should admit them quickly to the hospital, hydrate them, and immediately start to decompress the stomach by inserting nasogastric tube. Put them on PPI, antibiotics, investigate thoroughly, and then you can operate at ease. But during that, if they get worse, of course, you have to take them emergently. As for surgery, Now, this is a quick video here. It shows the hiatus here, the wide hiatus. The shiny part is actually the sac. I usually start the surgery by opening the lesser sac, and then identify the right crus and the left crus. Here, we are mobilizing the esophagus and resecting the sac. Now the sac is gone. The esophagus is here. Always make sure that you have enough length of esophagus inside the abdomen. Those are the crus, right and left crus. And then prepare for your fundoplication by dissecting or dividing the short gastric. Repair your hiatus by 2 to 3 stitches, unabsorbable stitches. And here you can, I usually use pledges to reinforce the repair. The fundoplication, you have to ensure that you have enough mobility of the fundus. I do something called a shoe shine maneuver, to make sure that they are not under tension, and then wrap up your surgery by doing fundoplication, either complete fundoplication or partial fundoplication. So three important points you have to understand: that in hiatal hernia, reduce the content completely. Make sure you excise the sac inside the sac of the hiatus. The reason is you don't want to end up having seroma and metastinitis post-op. The concept of short esophagus is very important to bear it in your mind. You have to have at least 3 to 4 centimeters of length inside the abdomen. Otherwise, you're going to have a recurrence of and failure of your repair. So if you don't have enough length of esophagus inside the abdomen, then you have to dissect more inside the mediastinum, or you do a lengthening procedure, which is a Colles gastroplasty. Make sure that you preserve both vagi, and of course, try to leave a peritoneal coverage on the crura. Why it's important to do a lengthening procedure of hiatal hernia? Because if you decided not to do, if you have short esophagus, the recurrence rate will be more than 42%, or about 42%. But if you did a lengthening procedure, the recurrence rate will drop down to 13%. The concept of short esophagus, you have to know it and you have to deal with it if you want to operate on the esophagus, especially hiatal hernias. What about giant hiatal hernia in elderly? An elderly with a lot of comorbidities, then what I do is basically I reduce and I fix. All right, so I do the minimum. An obese patient, probably I'm not the best one to talk about this, probably my distinguished colleagues will answer later on. An obese patient, the best treatment for those actually laparoscopic Roux-en-Y. This kind of procedure, it deals with the hiatal hernia, and it deals also at the same time with GERD and weight loss. Speaking of GERD, which is very common in the Western countries, and it's defined as a reflux of stomach content and into the esophagus, which causes symptoms and complications. We have 2 types of GERD. We have a pathological GERD and physiological. Pathological reflux, in which the patient comes with symptoms, usually with mucosal injuries, and the symptoms are usually at night, whereas physiological GERD is usually asymptomatic, postprandial, and rarely during sleep. GERD patients present classically with heartburn and regurgitation. Usually, the symptoms postprandial. To diagnose GERD, you have at least 2 episodes a week. Other than heartburn and regurgitation, they may present with dysphagia, chest pain, and sometimes with respiratory symptoms. Obtaining a proper history is very important in GERD. So you want to distinguish, or you want to distinguish alarming from non-alarming. And I'm going to tell you why it's important to know the patient have alarming symptoms or non-alarming symptoms. The non-alarming symptoms are the classical symptoms, the heartburn, a little bit of chest pain, and regurgitation. The alarming symptoms are the symptoms that may indicate a problem underlying. For example, weight loss, dysphagia, respiratory symptoms like aspiration pneumonias or chest pain. If you have alarming symptoms, and I think it's important to rule out other disorders like myocardial infarction. The evaluation of GERD, probably you can do barium swallow. The barium swallow will tell you, will not basically diagnose the GERD, but it tells you if there's any underlying anatomical problem or underlying complication of GERD, like ulcers, strictures. And barium swallow, to some extent, tell us about whether those patients, they have a short esophagus or problem with emptying, or if the patient have hiatal hernias or not. Endoscopy is very important in GERD to diagnose and to evaluate the esophagus in GERD. But we don't have to use it for everybody. So not everybody comes to us with heartburn and regurgitation. We have to do an endoscopy. Endoscopy is indicated for patients with alarming feature for more than 3 months, like for example, bleeding, iron deficiency anemia, weight loss, dysphagia, history of cancers in first-degree relatives, or those patients who have risk factors for Barrett's esophagus. For example, elderly, male, white, smoking, obese patients, or first-degree relatives with Barrett's. Those patients should be screened for Barrett's with endoscopy. Or if you are suspecting that this patient may have a complication of GERD, like esophagitis, or you want to rule out cancer. Never do endoscopy in this situation without biopsy. Biopsy is very important. Now, if you did your endoscopy and you encountered esophagitis, then we can, with endoscopy, we can basically grade the esophagitis by using the LA classification, which is a grading system by endoscopy, ranging from a very small, less than 5 millimeter non-communicating ulcers to the maximum, which is grade D, in which more than 75% of the circumference of the esophagus is ulcerated, and most of the ulcers are communicating at the top. Again, if you find esophagitis, I think it's important to biopsy to rule out underlying problems. In any GERD patient, I usually ask for manometry. I want to rule out an underlying mortality disorder. And then, again, I want to map and plan my surgery properly. To confirm your diagnosis, ask for pH monitoring. So the pH monitoring, we have 2 devices available in the market. We have the capsule, which is basically attached endoscopically just above the GE junction. And we have the conventional pH monitoring with a transnasal catheter in the esophagus. At the end of the day, you wanna basically get as much information as possible. In fact, one of my favorite pH monitoring studies is the pH impedance test. In this test, we can detect the non-acidic reflux or the weak acid reflux that may cause the symptoms of GERD. Once you collect information, usually we use a Demeter score to make sure or to confirm the diagnosis of GERD. This score is based on 6 variables. All of them depends on the PS less than 4. So the presence or the absence, the total number, the longest episodes less than 4. All this information basically will give us a total score of 14.7. If it is less than that, it's usually patient is not complaining or not diagnosed with GERD. If it's more than that, most probably this patient is complaining or is diagnosed with GERD. So the Meester score is not a must, but at least will guide you, to your diagnosis. GERD happens because of the gastroesophageal junction incompetence, and the incompetence may be due to transient LES relaxation. Many factors. This is one of the factors. Or due to hypotensive LES, or there is an underlying anatomical destruction of GEJ, like in hiatal hernia. But now, like recently, everybody is talking about the transient LES relaxation. The transient LES relaxation is a normal protective mechanism in belching and allowing the stomach to vent the air into the esophagus. During this venting, actually a lot of reflux happen here, and this factor or this transient relaxation occur when you have a gastric distension. When you have a gastric distension, basically you are initiating signals in the vagus nerve. And the LES will be relaxing, allowing the acid contact or the stomach contact in the esophagus. The other factor is hypotensive LES. We have many trigger factors or many medications or smoking or food that will decrease the LES pressure, and eventually the reflux will increase. Last but not least is the anatomical disruption, in which they, a lot of problems could happen in the anatomy of the esophagus. For example, the laxity of the crura, or increase the or hiatal hernia, or increase in intra-abdominal pressure, like in the gravid uterus. All these factors will lead to GEJ incompetence. One more thing is that the impaired clearance in the esophagus, or impaired esophageal emptying, and decreased saliva or poor saliva production. That means that the chance of the GERD will affect the esophagus is more, or the complication of GERD is more in the esophagus. So if you want to treat the GERD or try to treat the reflux disease, we have either medical or surgical or endoscopic treatment of GERD. Before you start your treatment, I think you should assess the patient for the need of upper GI endoscopy. But either or, what we do or what we ask for initially is ask your patient to change or to modify the lifestyle. So ask them to lose weight initially, or stop smoking, or stop alcohol if they drink, and change the diet. For example, a lot of food that decrease or increase the relaxation of LES. For example, mint, chocolate, garlic. those kind of foods will relax the LES more or decrease the pressure of LES and increase the reflux into the esophagus. So number one is lifestyle modification. Number two, you can definitely ask for, or you can put them on proton pump inhibitors or other drugs like ranitidine or antacids, but the best choice is PPI. PPI is not only control the symptoms, but actually it may heal the ulcers or esophagitis, and to some extent it will make the Barrett's basically regress. The course of PPIs is between 8 to 12 weeks, and I usually ask them to take PPIs an hour before meal. There are a percentage of patients that they don't respond to PPI. If your patient is not responding very well to PPI, I think you have to check the compliance first and check, or we have to restudy the patient again. So you have to do endoscopy, biopsy, impedance pH test study. The reason is because you want to rule out a non-acidic reflux in those patients. What about surgery? Surgery is not indicated for everybody. Surgery is indicated in failed medical treatment, for example, or the patient is intolerant or non-compliant to medical treatment, or patient is developing complications on PPI like severe esophagitis or strictures or Barrett's esophagus. Those patients with a large volume regurg, usually they fail PPI, then you can offer them surgery, or patients with respiratory or extra-esophageal symptoms like cough or aspiration pneumonias or asthma attack, or increased asthma attack. So the choice of procedures, we have endoscopic and surgical treatment for GERD. Endoscopic treatment, there are two in the market now, the Strata and TIF. TIF stands for transoral incisionless fundoplication. Although the data are not very encouraging, especially for Strata, but it's there and a lot of people using it. Both techniques are physiological repair, but they are not durable, or at least we don't have the long-term data for those techniques. Whereas a surgical, which is the other choice, we have many types or many techniques: laparoscopic partial or complete fundoplication, laparoscopic Hill gastropexy, or LINX, laparoscopic LINX. We're going to talk about them later. Those are very effective and durable, but the only problem that they have more or less the same side effects, which is difficulty in belching, bloating, and dysphagia post-op. So we're going to talk again about the anti-reflux surgeries and the possible complications, but I need you to remember those in the treatment of GERD. Remember that if you have an early uncomplicated GERD, think of Nissen fundoplication. If you have an underlying or any kind of motility disorder, always put in mind partial fundoplication, not Nissen fundoplication. Always bear in mind that there is something called short esophagus. That is, if you have intra-abdominal less than 2 centimeters or 2.5 centimeters, then put in your mind that, or plan ahead that I want to do some sort of lengthening procedure of the esophagus, like Colles gastroplasty. Patients morbidly obese with GERD, I think probably Roux-en-Y is the best choice for those patients because it deals with GERD and it deals with the weight loss also. Nowadays, we don't use a lot of transthoracic. Actually, most of us are doing laparoscopic technique, but we preserve or we save the transthoracic approach for the redo procedures, and the technique is Belsey's Mark IV. But you know, even Belsey Mark IV, Belsey Mark IV, actually, I've done it once or twice and not done anymore. So we'll move to GERD complications. The probably popular one is Barrett's esophagus. Barrett's esophagus is a pre-malignant condition in which there's a metaplasia of squamous epithelium replaced by columnar epithelium, and not any columnar epithelium, guys. You have to understand it should be an intestinal type with goblet cells, okay? Usually occurs at age average is 55, and men more than women, and occur in white more than black. So Barrett's esophagus is probably you know, results from GERD. Risk factors of GERD we discussed earlier, but like, you know, obesity, for example, hiatal hernia. If you have a family history, like first-degree relatives, the chance of getting Barrett's is about 30%. Smoking and GERD, they have some sort of synergistic effect. If you are smoking and have GERD, actually, there are probably 2 times a risk to develop Barrett's esophagus. Now, absence of H. pylori is actually is a risk factor. In fact, H. pylori has a protective mechanism, because H. pylori decreases the acid production in the stomach and causing atrophic gastritis. In order to have Barrett's, you need at least transition period between 5 to 15 years, and about 10% to 15% of GERD develop Barrett's. So not everybody of GERD develop Barrett's, okay? I just want to emphasize more that the epithelium or the columnar epithelium, it should be an intestinal type with goblet cells. Those types, actually, they have the higher cancer risk. But the other type, the gastric type, it doesn't carry any cancer risk. Barrett's esophagus may be transformed to adenocarcinoma, but before that, it develops dysplasia. And the risk factors of dysplasia and Barrett's is, for example, if you have a long segment, it carries risk factor of about 23%. There are drugs that may decrease dysplasia in this situation. The most common one is PPI. In fact, statins, they were found to decrease the dysplasia and adenocarcinoma by 41%. So if you have dysplasia, especially on biopsy, it is divided into 4 findings. So the dysplasia is categorized: either the biopsy has no dysplasia at all, or the biopsy is indefinite for dysplasia, or there's a low-grade or high-grade dysplasia. What I'm worried about is high-grade dysplasia, because it carries an annual risk of about 7%. Anyways, any diagnosis of dysplasia, it should be confirmed by 2 pathologists, 2 experienced pathologists, all right? And this is very important. So back to adenocarcinoma, in which there will be an increased proliferation and decreased apoptosis. But we have to understand that not every Barrett's will be converted to adenocarcinoma or develop adenocarcinoma, only small percentage, and 90% of adenocarcinoma, actually, they don't have Barrett's esophagus, okay? Patients with Barrett's may have no symptoms or GERD symptoms, but if you have GERD and esophagitis, you have a 5-time risk to get Barrett's esophagus in 5 years. So how do we evaluate Barrett's? By endoscopy and biopsy. Recently, there are a lot of endoscopic techniques emerged. the MBI, which is the narrow band elimination. When you see like a tongues of the Barrett's esophagus here, or they inject the esophagus with a dye. It's called chromoendoscopy. Or last but not least here, or more recent, actually we use something called cytosponge, in which the patient to swallow a capsule, and then they do some sort of brush biopsy, and then they take it for histopathology. Shall we screen everyone for Barrett's esophagus? The answer is no. We screen only those patients who have high risk for getting Barrett's esophagus. For example, a patient with alarming symptoms, then we have to do upper GI endoscopy. Or, for example, patients that are males, obese, smoking, with hiatal hernias, more than 50 years of age. Those patients are prone or they are basically eligible to get upper GI endoscopy to rule out Barrett's esophagus. So for management of Barrett's esophagus, you have to bear in mind two things: to control or to treat the acid reflux, and to do some sort of monitoring for those patients or surveillance for those patients. So I usually start treatment with what I mean is aggressive treatment for reflux. So I put them all on PPI, the maximum dose, probably for 8 to 12 weeks. With PPIs, there will be some healing of esophagitis and some partial regression of Barrett's esophagus. And the monitoring, of course, if you decided to do upper GI endoscopy for your patient, then on the initial endoscopy, you have to do a biopsy 4 quadrants every 2 centimeters. And if you have any suspicion of dysplasia, then you should confirm it with 2 pathologists. So after the initial endoscopy, if your patient is without dysplasia, then ask to do a surveillance endoscopy every 3 to 5 years. But if your patient is indefinite for dysplasia, but they don't know whether there's dysplasia or not, then you should continue treatment with PPI, optimize it for 8 weeks, and repeat upper GI endoscopy with biopsy every 1 centimeter, 4 quadrants. Make sure that 2 experienced pathologists, they look at it, and if you have a Barrett's esophagus, then basically repeat your endoscopy and biopsy every 12 months. In low-grade dysplasia, again, I keep emphasizing that 2 pathologists should look at it. But in low-grade dysplasia, you can continue the PPI for 8 to 12 weeks and repeat the endoscopy biopsy every 1 centimeter, and make sure that those patients are followed with upper GI endoscopy every 12 months. If you have dysplasia, like high-grade dysplasia or carcinoma in situ, for example, then we have choice of endoscopic eradication. But before that, actually, you have to study your patient properly. Like, whether the patient's age is appropriate, patient has a lot of comorbidities, whether you have, whether you have your local expertise are very experienced or not in endoscopic eradication, and of course the patient preference. So we have options if you have high-grade dysplasia or carcinoma in situ. The options of ablation is, or the options endoscopically, either you ablate the high-grade dysplasia or carcinoma in situ with IRF-A, radiofrequency ablation, or photodynamic therapy. And this technique, the problem with this technique that you need repeated sessions, and those people actually, they might develop strictures after the procedure. And unfortunately, with this kind of ablation, that you don't have an actual pathology. So there's no tissue that you study. And the recurrence is very high. The second technique, endoscopic resection, endoscopic mucosal or submucosal resection, is probably fairly new, like in the last 10 years or 12 years in the market. And this technique, you can, or you will achieve complete eradication of the dysplasia or in situ in about 80% of the time. And this technique, you have an actual tissue that you will study. So you study the involvement of the thickness of the disease and whether the margin is clear or not clear. Last but not least, in high-grade dysplasia, usually, well, actually not usually, but the old school or the standard school is you do a esophagectomy. I remember that we've been taught any high-grade dysplasia or carcinoma in situ, those patients straight away for surgery. So we do a total gastrectomy and total esophagectomy and gastric pull-up. But the problem with esophagectomy, of course, they have a high mortality rate and high morbidity rate. The question comes now: is there a rule of anti-reflux surgery in Barrett's esophagus? Well, you know, it's debatable and really controversial. Surgery in Barrett is very good in controlling symptoms, and definitely it will improve the quality of life. To some extent, you have regression of Barrett's esophagus. But if you compare it to PPI, proton pump inhibitor, we have level 1 data now, RCTs comparing PPI to surgery. They concluded that there is no differences in progression of dysplasia and adenocarcinoma between PPI and surgery. So whether we operate or not to operate, I think it depends on symptoms or how severe is the symptoms. But in terms of progression to adenocarcinoma, I think there is no difference. The other complication of GERD besides Barrett's esophagus is peptic esophagitis. I guess we discussed that earlier. The treatment of peptic esophagitis is basically the modification of lifestyle and start them on PPI. The problem with PPI with esophagitis, they may recur after stopping the PPI. If those patients have persistent symptoms, then think of other stuff like non-acid reflux problems or the medication is not working anymore, which is tachyphylaxis, and you have to re-investigate again with impedance 24-hour PF study to rule out weak acid or non-acid reflux. The third complication of GERD is esophageal strictures, which is a chronic inflammation from GERD or from peptic. It's called peptic ulcers. The most famous one is Scatzer's ring, which is a web-like scar at the squamocolumnar junction. We see it a lot with hiatal hernias and GERD. Those patients usually present with dysphagia and or acute obstruction. We call it steakhouse syndrome. Most of the time, the patient comes to us after a heavy meal, basically like a steak or a large amount of bread being ingested. So other presentation is chest pain and sometimes extraesophageal symptoms like aspiration pneumonia. The golden test for stricture is barium swallow. You can easily diagnose that, like we see here. But definitely upper GI endoscopy is crucial. We can use upper GI endoscopy as for both diagnosis and treatment. The treatment of Scatzer's ring is always, you should always start with dilatation, either balloon dilatation or Sabry or bougie dilatation. But remember that it should be guided dilatation. You want to decrease the risk of perforation as much as possible. So that's why I use rule of three. The rule of three is that you should only dilate up to 3 sizes in one session. Don't go for that, more than that. The relief is immediate, and the relief is actually is probably more than 80%, but the recurrence ranging between 12 and 65%. If that you think that dilatation is not the proper thing to do, I think, or the patient is poor candidate for surgery, you can definitely apply stent in the esophagus and keep the stent for 4 to 12 weeks. The problem with the stent is that they might migrate, erode, or fistulate. We can add to the dilatation a local injection with corticosteroids. So basically, it's a combination between balloon dilatation with corticosteroid injection. It has been shown that it decreases the repeated dilatation, or the need to repeat dilatation, from 60% to 13%. The rule of anti-reflux surgery in Scapes rings or peptic strictures, it's valid, and we keep it for those who failed medical treatments. But before offering anti-reflux surgery, always keep in mind to start with PPI and dilatation with corticosteroid injection or without corticosteroid injection. Last thing here in peptic strictures is the esophagectomy or esophageal resection, and those this procedure is basically reserved for people with failed multiple anti-reflux surgery or the end-stage recalcitrant strictures. The procedure is basically total esophagectomy and gastric pull-up. Fourth complication of GERD is something called short esophagus. The short esophagus, I know we talked about it earlier, but I want to emphasize it more, and I want to press on it because it's very important concept. Is an intra-op diagnosis when you have the intra-abdominal esophagus is less than 2.5 centimeter. Okay, usually due to longitudinal scarring or large hiatal hernia, and the short esophagus could be diagnosed by barium endoscopy and manometry, but definitely the best diagnosis should be an intra-op. How can we predict that this patient is having or will have a short esophagus? Is by the following. So if the patient actually having a large hiatal hernia or a severe esophagitis or complicated GERD by strictures and Barrett, those are indicators of short esophagus. Now, the treatment of short esophagus is two things. First of all, you have to do an extensive mediastinum mobilization, at least like 8 to 10 centimeter inside the mediastinum, or a lengthening procedure. We call it a gastroplasty, Colles wedge. So in Colles wedge, we create a neo-esophagus inside the abdomen or longer esophagus by wedging 3 to 4 centimeters from the fundus. Okay, with Colles wedge or gastroplasty, the recurrence rate will decrease or will be reduced to 13%. So I promise you we'll talk about the anti-reflux surgery. Anti-reflux surgery is indicated for the indication is two things. Either the pills doesn't work or don't work, or the problem, patient develop problem despite pills. So pills don't work, that means that symptoms relapse while on treatment, or relapse right after the treatment stopped, or the patient is non-compliant to the medication. Problems despite pills simply that the patient developed complication on, for example, strictures, Barrett's esophagus, esophagitis, etc. So anti-reflux surgery could be conducted by open technique or minimal invasive technique. In minimal invasive technique, either laparoscopically or by robotics or endoscopically. We have two types or two classification of anti-reflux surgery or fundoplication, either complete fundoplication or partial fundoplication. So complete fundoplication is called Nissen. This is the most popular one, in which there's a 360-degree wrap around the esophagus, like here. The partial fundoplication, we have two types or two techniques. Toupet fundoplication, in which there's a posterior 270-degree wrap around the esophagus, behind the esophagus. The door fundoplication is 100-degree anterior to the esophagus. In fact, there is most of the data basically concludes that those actually fundoplication are equivalent, they have equivalent outcome and symptoms relief. To lesser extent or less common than those fundoplication, we have a Hill gastropexy and Belsey's repair, which is a transthoracic posterior application. Overall, Nissen fundoplication, they have better GERD control of the birth control or GERD control, but the problem that there's a risk of dysphagia and gas bloating after the surgery. So, in order to proceed with your surgery, the position is usually supine, steep reverse Trendelenburg position. Usually 5 trochers. I like to use 2 10 millimeter or 10, 11 or 10, 12 millimeters trochers. And then, how it's going to work. Sorry, there's a glitch here, but anyways. Sorry for that. All right. So I start my procedure by opening the Lister sac. At the end of the Lister sac, I identify the right across here, and then start opening the phrenoesophageal ligament. Always make sure that to leave peritoneal cover on the crust, and always try to preserve as much as possible the vagus nerve. I usually divide the short gastric to prepare for my fundoplication, like here. Then I continue exposing the left crust and make sure that I mobilize the esophagus very well to ensure a good length inside the abdomen, at least 3 to 4 centimeters. So here I'm creating a window behind the esophagus to help me with the retraction and help me to mobilize the esophagus more. Then we start closing the crura with 3 or 4 non-absorbable sutures. Then the fundoplication repair here. Before I do fundoplication, usually pass size 50 or 52 bougie, and then we do our fundoplication. The wrap, you need probably 3 to 4 centimeter wrap to ensure a good anti-reflux surgery. All right. We'll skip that. So the question, Cam, is whether to use a mesh or non-mesh. In fact, we don't know. There's, I can defend both schools, but I think it depends on your assessment intraoperatively. If the repair is weak or the crura or diaphragm is weak, I think you should reinforce it with the mesh. If you want to use mesh, make sure you use a soft one. the most popular one probably is biological mesh. Again, whether you do a Colles gastroplasty or not, it depends on the length of the esophagus, whether you have more than 2.5 centimeter inter-abdominal length or not. All right. Usually post-operatively, I keep those patients on regular pain control and antiemetics. Next day, we'll ask for barium swallow. If they pass the barium nicely, then I start them on a fluid diet, discharge them on a soft diet for 4 to 6 weeks, and I continue the proton pump inhibitors for another 6 weeks. Post-op complication, post-fundoplication, the most popular one or most common one is dysphagia and gas bloating. Usually lasts for about 6 weeks. Sometimes you have recurrent GERD or recurrent symptoms. So if you have recurrent symptoms, then I would advise to continue PPI, or you think of revising the whole procedure. But sometimes you have to investigate more to rule out esophageal or gastric dysmotility, and you have to make sure there is no anatomical failure. Anatomical failure, which means that we have basically failure in our technique. So we have 4 types or 4 categories. The first type is you have undone rab, meaning that everything falls apart. The second type of failure is when you have a tight rab. If you have a tight rab, the patient will complain from dysphagia or inability to belch or vomit. The third possible complication is a slipped rab. A slipped rab is when your rab is basically too loose, so that the stomach is slips between in the rab. So your rab now is actually not around the GE junction, it's actually around the stomach. The most common one is actually herniated rab. The whole thing is now above the diaphragm. Partial fundoplication is usually recommended if you have some sort of motility disorder. So, like for example, if I have GERD with motility disorder, then I basically proceed with toupee. If I have achalasia, of course, I would proceed for door fundoplication. So, toupee fundoplication again is posterior fundoplication, partial, 270. Door fundoplication is anterior fundoplication. It's like 180 degrees. I came across during the literature review with this procedure. I never done it, but I've seen it probably once. It's in which there's a magnetic augmentation of LES, utilizing or using this ring or these beads. It's more or less the physiology and the outcome are exactly or more or less the same as Nissen fundoplication, but you know, it doesn't require a lot of mobilization or a lot of dissection intra-op. So the possible complication with the LINX procedure is dysphagia, and probably rarely erosion was reported. The immediate outcome is very promising, that most of patients are off PPI within 2 weeks, and the long-term outcome, actually, again, people are satisfied with the results, with some even Barrett's regression. Lastly, in this section, there is something called Hill gastropixie. Again, Hill gastropixie, not everyone use it or do it, but the idea behind it is actually enhancing the angle of His by suturing the anterior and posterior phrenoesophageal bundle to the arcuate ligament. So the arcuate ligament is actually this ligament just above the aorta. So you are like basically you're like playing with fire here. Unless you are experienced, then you don't have to do it or don't do it. Now, the last section of this review is motility disorder of the esophagus. So the primary motility disorder of esophagus has been divided into three major categories. The first one is the esophageal gastrojunction outflow obstruction, like in achalasia, major disorder of peristalsis. The examples, for example, is the distal esophageal spasm or jackhammer or absence contractility. The last one is minor disorders of the peristalsis. The diseases under it is like ineffective motility and fragmented peristalsis. Now, those categories or division is based on based on Chicago classification version, third version. Patient underwent high resolution manometry, and they measured basically the resting pressure of the lower esophageal sphincter and whether there is peristalsis or not, no peristalsis, and again whether the contraction is strong or vigorous or not, for example, or there is no contraction. Having said that, the most common motility disorder that we encounter is achalasia, which occur like in 1 in 100,000, and it is characterized by three things that you have to remember. Achalasia must have failure of LES relaxation during swallowing. They must have air peristalsis and elevated LES pressure. Those three are a must in achalasia. We have primary achalasia and secondary achalasia. Primary achalasia, the reason or the etiology is unknown, but it was found that there is a degeneration of ganglia and myotrain complexes. Secondary achalasia is actually there are many causes like Chagas disease, sarcoidosis, but the most common is underlying cancer of the cardia. Almost all of the achalasia patients present with dysphagia to both solids and liquids. Other symptoms depend on the severity of the disease. So they may present with weight loss or chest pain or aspiration pneumonia. And if achalasia is neglected, then they will end up having megaesophagus, and rarely they develop squamous cell carcinoma due to the fermentation of food inside the esophagus. So based on the symptoms of esophagus, there has been a scoring system. It's called Eckerd scoring system. So they score whether the patient has dysphagia, regurgitation, chest pain, or weight loss. Zero score or 1 score is very mild disease, but if its score is more than 6, that means it's stage 3 disease or severe achalasia. Severe achalasia meaning that the dilatation or diameter of the esophagus is more than 6 centimeters. There will be some sort of angulation, distal angulation. Patient actually may have a sigmoid esophagus or megaesophagus, which is defined as a diameter more than 10 centimeters. So to evaluate the achalasia, definitely we start with history and physical examination, and then I ask for barium swallow. Classically, in barium swallow, it shows dilatation of the esophagus and a bird's beak, which is this area here where the LES found. And of course, to some extent, actually, we may assess the peristalsis with barium. Endoscopic upper GI endoscopy, classically or classical finding, we see usually a dilated esophagus, some retained food here, and difficulty to pass the scope through the LES. But the gold standard to diagnose achalasia is actually manometry. Nowadays, we use high resolution manometry, the 3D manometry. So as I said, it's a gold standard. In achalasia, the manometry will show us the patient of achalasia will have air peristalsis, failure of the LES to relax during swallowing, and increased LES baseline or pressure, more than 45 mercury. The esophageal body is also increased in pressure. And we sometimes we see that those patients have simultaneous non-coordinated contraction, which is tertiary peristalsis. Of course, if you have achalasia, you have to think of other stuff or other differential diagnoses like GERD or complication of GERD or some sort of extrinsic compression like in cancer or paraneoplastic achalasia, and so on. So after you diagnose the achalasia by high resolution mortality, then we can classify them. So we have 3 types of achalasia based on the findings. We have type 1 achalasia. Type 1 achalasia, in which we have actually elevated resting pressure of LES and absent contractility. Okay. Type 2, again, elevated resting pressure and absent peristalsis, but there is a pan-esophageal pressurization, at least more than 20% swallows. Type 3 achalasia, in which we have absent peristalsis and tertiary or premature contraction, more than 20% of swallows. Those are basically classification or clinical types of achalasia. The treatment of achalasia is aimed to decrease the hypertonic LES and improve emptying so that we prevent dilatation of the esophagus. And we can achieve this either endoscopically or surgically or by medical, but most of the time actually endoscopically and surgically. So medical treatment, we reserve this treatment for poor surgical candidates and those patients that are waiting for definitive surgery. The drugs are used most of the time is calcium channel blockers like nifedipine or long-acting nitrates. If the patient undergo or underwent endoscopy, we can definitely utilize Botox injection. The problem with Botox injection is that it creates a lot of inflammation around it, making the surgical myotomy more difficult. But again, the Botox injection should be repeated every 6 to 24 months. The good thing about Botox is actually we can use it if we have failed myotomy surgery. The second endoscopic treatment is actually pneumatic dilatation. Again, we can do it for those patients who had surgery and failed. But the problem with pneumatic dilatation, balloon dilatation, is that we need to do it more than once, more repeated sessions. And again, the problem with pneumatic dilatation is that it makes the surgery afterward more difficult because it creates a lot of inflammation around it. Imagine that you operate or do your myotomy on a scar tissue. It's going to be really difficult, and the risk of perforation will be high during surgery. the last endoscopic technique that, and recently being more increasing in popularity, is POEM, which is peroral endoscopic myotomy. POEM is actually a very good procedure, an excellent procedure, and the results of it is really good. It is safe. It has low complication. Even the perforation rate is pretty much low. And the outcome more or less is same as myotomy or dilatation. So what happens in POEM? Usually it involves injection of the submucosal area with dye or with normal saline, and then they create a tunnel between the mucosa or submucosa, and the tunnel should reach onto the stomach at least 2 to 3 centimeters. They use a special knife in the tunnel to cut the inner circular muscle, basically concluding their myotomies by closing the tunnel with endoscopic clips. The possible complication is perforation that we're worried about, and unfortunately, so far we don't have a long-term data for the effects. But so far, the people are very happy. The satisfaction is very high, and the complication is very low. So far, or till now, the gold standard treatment of achalasia is actually Hiller's myotomy. Hiller's myotomy always associated, or you should include partial fundoplication. The reason is when you do a Hiller's myotomy, you're basically breaching the defensive mechanism around the esophagus. So most of those patients, they will come with reflux disorders. The aim of Hiller's myotomy is to open up the muscles and open up the lower esophageal sphincters to relieve dysphagia. And the most common complications is perforation and GERD. So usually during Hiller's myotomy, we don't need a lot of mobilization. But once you identify the esophagus, you start to open up the layer above the esophagus and start basically cutting the muscle until you get the submucosa bulging out. We'll see it shortly. So the myotomy required is actually you need 4 to 5 centimeters in the esophagus, and you have to do myotomy probably 2 to 4 centimeters on the stomach. Okay, here we are basically the surgeon is measuring the myotomy. As I said, we need total of 7 to 8 centimeters, and probably a crucial step is to do the myotomy, extend your myotomy into the stomach. At the end, make sure that you complete your surgery by doing a partial fundoplication. We usually like to do a door fundoplication, which is anterior wrap 180, and the reason is because it prevents reflux. And it covers the myotomy. Okay. So post-operatively, I usually keep them fasting till next day, and then I do like gastrograph and swallow. If they fasted, then start soft diet for 2 weeks. And I always tell my patient, you know, if you want to eat, just eat small bits and bites. Having said that, a transthoracic approach is not done anymore. We have esophagus, omega esophagus, more than
more than 10 centimeters or 8 to 10 centimeters. This is an actual patient we've done a couple of years ago. As you can see, how big is the esophagus? Actually, more than 10 centimeters here. This is our fellow, and now he's completing his thoracic fellowship in Canada. The patient is very happy, and the patient is doing very well so far. Other mortality disorder, which is esophageal gastric junction outflow obstruction. The obstruction either intrinsic or extrinsic, but the high resolution manometry usually shows elevated resting pressure of lower esophageal sphincter and preserved peristalsis. So in achalasia, the peristalsis is gone. There's no peristalsis. And here in EGJ outflow obstruction, the peristalsis is preserved. The treatment for this condition is more or less the same as achalasia. We start with PPI, calcium channel blockers, some sort of dilatation of vortex, and last but not least, we do myotomy and fundoplication. Usually fundoplication is partial fundoplication. The other category of motility disorder is called major disorder of peristalsis. Those patients always have symptoms like chest pain, dysphagia, and regurg. Those are spastic contraction. And the most popular one is the distal esophageal spasm, aka diffuse esophageal spasm. This disease actually is due to a lot of premature contraction occur in the esophagus. So premature contraction is more or less more than 20% of the swallow, and the high resolution manometry reading, usually they have normal LES resting pressure, reduced distal latency. The DL is the interval between initiation peristalsis at the level of upper esophageal sphincters until the deceleration of peristalsis. So if the interval between the contraction is reduced, that means that we're going to have a lot of contraction, and a lot of them is going to be premature contraction. Classically, barium shows corkscrew, as you can see here, and the treatment same as other motility disorders, behavior modification, diet, medical treatment, pneumatic dilatation, and myotomy. Here, the myotomy, of course, is not going to be short. It's going to be long myotomy, maybe from the stomach up to, or from the hiatus up to the aortic arch. The other disease is jackhammer esophagus, in which the contractions are vigorous contraction. The DCI, which is the distal contractility integral, that means it measures the strength of contraction, is usually more than 8,000. Normally, the DCI is between 450 and 8,000. So if it is more than 8,000, it's definitely going to be very strong, very vigorous contraction. The other esophageal motility disorder is called nutcracker. Nutcracker esophagus, it's hypertensive peristalsis, but the DCI here, which is the power of contraction, is between 5,000 to 8,000 mercury. Those patients are not always symptomatic. In fact, those patients may be passed as normal if you read the high resolution manometry. So the treatment, those patients usually control spasm by giving them calcium channel blockers or change their behavior or modification of lifestyle, and or endoscopic or surgical myotomy. Again, it's going to be a long myotomy, not like achalasia myotomy. Last thing in the motility disorder is something called hypertensive LES. In hypertensive LES, the pressure in lower esophageal sphincter is more than 35 mercury. And this condition is like 20% associated with epiphrenic diverticulum. And the treatment of hypertensive LES, again, is more or less the same thing, either medical treatment, like Botox, calcium channel blockers, or endoscopic dilatation, or lastly, you can definitely do myotomy, and it's going to be, again, myotomy, actually, with diverticular resection, so that you will have a good result with this kind of disease. And again, if I did myotomy here, I would basically include partial fundoplication. So thank you very much. I know it was really long, but for references and further questions, you can contact me on my email, and I'll be happy to help. Hamid?
Thank you very much, Doctor, for this informative session. And I think we can put the questions, the 5 polls now, and see the response if it's possible. All right?
Sure.
Sure. So we'll start now.
All right. So the first question, again, Zinker's diverticulum protrudes through Killian triangle. Killian's triangle is bordered A, inferior constrictor muscle and cricopharyngeus muscle, superior constrictor muscle and cricopharyngeus muscle, upper esophageal wall and cricopharyngeus muscle, D, inferior constrictor muscles and esophageal wall.
30 seconds. You can feel free, Doctor, to look at the question, the Q&A panel, to choose any question you can answer after the poll. Almost around 14 questions, so some of them you might answer it in the session.
I don't think it's well, I don't think. All right.
So we'll share the result now of the current.
Sure. That's excellent. I'm very happy, actually. That is correct answer. Most of you answered the correct answer. So remember the first couple of slides, we said Killian's triangle is the bare area of the esophagus, and it's bordered superiorly by the inferior constrictor muscles and inferiorly by the cricopharyngeal muscle. So that is the correct answer. Excellent.
All right, we'll go for the second question now.
All right, the second question is, the usual incision given for surgery of Zinker's diverticulum is left cervical incision, right cervical incision, suprahyoid or midline cervical incision.
Give them 30 seconds more.
All right. What are the thoughts on reports of buried high grade space after resuscitation? Can chronic GERD lead to malignancy of esophagus? Yeah, I guess the short answer is yes. So one of the questions is, can chronic GERD lead to malignancy of esophagus? The short answer is definitely yes.
All right.
Regarding PPI, as there are studies link, I cannot answer this. I'm having technical problems here.
All right. We're going to share the second question results. You can see it now.
All right. So, yeah, absolutely. So the usual incision is actually left cervical incision. The reason is that and in the left cervical or the left neck, the recurrent laryngeal nerve position is predicted. Basically, we know where the recurrent laryngeal nerve. Usually, it's in the groove between the esophagus and the trachea. But on the contrary, on the right side, a lot of times, the recurrent laryngeal nerve is not in the groove. Actually, we have variation. So to be safe, the left neck incision is the safest approach for Zinker's diverticulum. Excellent, guys. Very good.
We'll go for the third question now.
I'm having trouble visualizing my okay. Questions, yeah.
So the third question is on now.
Okay, I don't know. Well,
so for the third question, what is the type? What is type 3?
My computer is having hiccups actually. That's how much risk is surgery and octogenarian? Yeah, I guess there is the question is here is how much is the rate of success of surgery in octogenarian? Do they lead to a normal life after thereafter? The answer is I don't have of hand like the rate of success, but what we know, or what most reports basically recommends, that octogenarian, especially the healthy ones, they should undergo, or they may undergo the surgery safely, and definitely they will have a normal life after that. And the occurrence rate will be definitely less, with less complication of hiatal hernia or GERD. All right.
So the results are out for the third question.
That's the third question. What is this? All right. So the question was what was the type 3 esophageal hernia? And definitely it's a combination between type 1 and type 2. That's type 3. Excellent. Guys, I'm really impressed.
That's good.
Really paying attention. Although it was very long, I'm getting tired here.
We'll go for the fourth question.
Okay. So the fourth question is, in GERD, endoscopy is indicated in all except dysphagia, anorexia, iron deficiency anemia, heartburn, or none of the above. So GERD is not indicated, or is indicated in all of them except one.
We'll give them 30 seconds.
What can be treatment option for severe cryptic ulcer? Okay. Oh wow. Well, you got it. Remember we said that the endoscopy in GERD is not for everyone, and usually it's reserved for those patients with the alarming symptoms like dysphagia, anorexia, weight loss, and iron deficiency anemia, whereas heartburn and regurgitation are classical non-alarming symptoms. So most of you, they got it right, 32%, which is good. So the answer is D, the heartburn. Not everyone with heartburn should undergo endoscopy.
Right.
All right?
The last question for today then.
All right. Last question, the gold standard test to diagnose achalasia is barium swallow, CT scan, high resolution manometry, endoscopy, or endoscopic ultrasound. The gold standard for achalasia.
We'll give them 30 seconds.
Sure. All right.
Ending the poll now.
Yeah. Excellent. That is correct. The gold standard to diagnose achalasia is actually manometry, not barium swallow, guys. Barium swallow has classical signs or classical symptoms of achalasia, but definitely high resolution manometry is the tool to diagnose or to confirm the achalasia. That's really good. That's really good. You did great, guys.
Thank you, doctor. If we have a few more minutes, if you want to answer one or two of the questions in the Q&A panel.
To be honest, I'm having a lot of problems here.
So we can to put them together, because we're going to have another session with you on Wednesday. So we can review better for the next session.
Excellent.
Okay.
Excellent. Thank you very much. Thank you, everybody.
For this informative session. We really enjoyed it, and we can't wait for the second session it's going to be on Wednesday, same time, about the second part of the esophageal diseases. Thank you so much, Doctor.
Thank you. Hopefully it's going to be shorter than this one.
We enjoyed it, Doctor. Just a few announcements before we end. We're going to pull out the QR codes now, so you can register directly for the next session, which is going to be on Wednesday, and it's going to be the second part of esophageal part 2. Thank you again, Dr. Derar, and hopefully we'll see you on Wednesday.
Pleasure. Thank you very much.
So feel free to take out your phone, scan the QR code in the middle for the surgical fix. You can also visit our Instagram, Twitter, and website for the previous session, and listen to our sessions over the podcast on Spotify and Apple Podcasts. Don't forget to fill out the survey before you leave. Thank you so much, everyone, for attending, and thank you, Dr. We'll see you on Wednesday.